Hello and welcome dear learners to the NPTEL course on Healthcare Quality Management, Infection Control and Patient Safety. In the Module 4, Clinical Governance, Leadership and Risk Management in Healthcare, for the chapter 48, we will be studying on Risk Management in Hospital and Healthcare, Part 4. It will deal with two case studies, that is case study 1 and case study 2. In these two case studies, we will be studying about case study 1 of proactive risk assessment of surgical swab counting using HFMEA, which we have studied in the previous chapter, and case study 2 will talk about the breakdown in patient identification and handover, a system, culture and risk management perspective. And the key learnings from these two case studies will be also discussed. In the case study 1, the proactive risk assessment of surgical swab count using HFMEA, which is very common actually into a surgery, a problem which is being seen in most of the hospital, and if you are trying to understand the risk and analysis of this, you can take the benefit of this case. The case background I want to give you, like from the literature review, it shows that the incidence of missing surgical swab is 1 is to 5,500 surgeries. So you can understand that in 5,500 surgeries, one surgery you will come across a missing surgical swab. So what is the proactive risk assessment to understand that the risk happening actually, and before that how you need to tackle this? Though the event is infrequent and the consequences are catastrophic, the retained surgical swab can lead to severe patient harm, can lead to reoperation, and also can lead to legalities like legal action and reputational damage, which is a very severe, and for this you have to take a stepwise HFME approach, which is used to proactively analyze the risk to tackle whole lot of these issues to happen. Step 1 deals with define the HFMEA topic as what we have seen in the previous lecture. With this, we are taking now this case study ahead for discussion. The HFMEA topic identified is over here as process of calculation and counting of surgical swab during the surgery, which is a very meticulous plan actually to take ahead of selecting the topic first and then understanding the severity and the high risk. The topic selection was based on the severity of the potential harm that can happen and the high risk of single point failure process. Now you have to work on identifying the team or assembling the team as step 2. Multidisciplinary team constituted surgeon 2 to 3, operation theatre nurses 2 to 3, including OT supervisor and quality officer. This is a team which has assembled actually to identify the surgical swab and the counting and the calculation of it. There is a team manager, or I mean to say a team officer, who can take the moderation responsibility, and usually it goes into the hand of quality officer. The importance of the team is like the quality of the HFMEA depends on the knowledge, motivation and engagement of all the team members over here. And we have seen the involvement of surgeon, operation theatre nurse, OT supervisor and even the quality personnel. In the step 3, they will do the graphical description of the process, what they have done, that they are doing surgical swab counting process broken into sub processes and further sub processes, which they will make a flow diagram developed on those process and sub process. And each of the steps is numbered subsequently to identify the vulnerable points and focus analysis on the critical steps, which will give them the entire picture of the process. And next level in step 4, they will conduct the hazard analysis, which is comprising of possible failure modes identified for each sub-process. The example can be incorrect swab count during the surgery, which was being seen as one of the possible failure modes. The potential cause identified was nurse fatigue during the prolonged surgery. Might be she has taken a previous surgery and then has come for the next, which has given her a fatigue actually, which is leading to the counting, or lack of concentration actually of the team members actually who have conducted that surgery. Swab sticking together, or sometimes swab falling unnoticed or drapes or floor, which is also a possibility. The possibility are listed actually in the chronology that are most likely to happen. Document the causes in the HFMEA worksheet which is there and which can give you an idea like what are the potential causes actually which are identified in this hazard analysis. In the step 4, severity, probability and hazard scoring is being given, which is according to the tables and the risk plans actually that we have seen in the previous chapter. The severity is assessed using the severity rating table. Missing swab can lead to death or major harm, so severity score like 4 for catastrophic and occasional 3 and further lesser to it. So probability assessed using literature and hospital workload, estimated as occasional score 3. Hazard score calculated 4 into 3 is equal to 12. So you can understand the hazard score uh, above 8 and it requires a further action. In the step 5, we can see the action plan for the incidents. What they have been developed actually to see that the plan is developed more on the identified control measures. Avoid long working hours for nurses is one a plan. Second is mandatory counter check by the floor nurse actually on the incidents. Documentation in the swab counter register, which is a very important way actually to deal this issue. And especially according to the WHO checklist, counter signature by the consultant is very important to have a double check. And 100% compliance with the surgical safety checklist is a need which will give you the major control measures for this issue. And responsibility is assigned to the OT in charge of whole of this action plan. And what is the target timeline? The target timeline is 1 month where you can see the implementation happening and you will get the best of the best benefit if you are executing it into this way. The step 6 will be follow up and review. If though the audit conducted after 1 month, the team has taken the action plan for 1 month, they have done it and the compliance was checked actually. The compliance will be checked with respect to checklist usage, register maintenance and even the team actually who is taking this. The recalculate hazard score severity is equal to 4 and the probability reduced is to 2, which is uncommon, and the new hazard score is 8 where you have seen the previous it was 12. Okay, and when you try to see that it has reduced to 8, the risk is significantly reduced through double checking. It is not possible that it will reduce from directly 12 to 4 or 6, but yes, definitely the HFMEA to be periodically if revisited for sustained compliance, it will give a great benefit that follow up and review will make a drastic change. Now the HFMEA case study. The case study is of missing surgical swab during surgery, proactive risk analysis and mitigation. You have defined a topic, assembled a team with surgeon, nurses and experts and quality members, map the process, hazard analysis is done and the score was identified to 12. After the HFMEA we have seen into this case study, the score has reduced to 8, which is like they have made an action plan which is avoiding the fatigue, mandatory counter signature which is being done at the OT register actually, and it is being seen that OT person is giving a responsibility as a manager. Follow-up is done, audit and compliance and the new hazard score is reduced to 8, which is more in aligned to the WHO checklist and double checks which has been followed. So you may find a great benefit actually for this previous case study that has been recorded for the surgical swab. Now in the case study 2, you will find a breakdown in the patient identification and handover, which is also a very common problem to be seen in our country. And we find that a lot of failures actually which are more counted actually for an individual person, a system, a culture and a risk management perspective has been seen in this particular case study, and we need to appeal actually that most of the reason that patient identification and handover which becomes a major issue with respect to risk need to be tackled with the help of this perspective. What is this perspective? We will try to understand. In this particular case scenario, a 450 bedded tertiary care teaching hospital performs a high volume of elective and emergency procedure. So you can understand with this case scenario that over a 6 month the quality department notices an increase in near miss events which are related to patient identification and clinical handover, which is a slow and steadily developing a major problem. This problem was identified particularly during the night shift and the inter-department transfers. So if you understand this and you have taken the entire view of the hospital over here, you can understand the sequence of events. The sequence of event can be depicted as a patient scheduled for CT guided biopsy is transferred from the ward to radiology. But due to heavy workload and time pressure, the ward nurse sends the patient without verifying two patient identifiers. She has not done, or it is because of the workload there was a fault, or there was no double check also which is making a system fault, or multiple line fault were identified in this sequence if you understand the events. In the radiology department, the technician relies on the verbal communication which was given by the nurse and instead of checking the wristband, which could have even reduced the possibility of the near miss. The procedure is stopped just before initiation when the consultant notices a mismatch in the clinical history. The consultant has noticed that there is a mismatch into the observations or has been seen that what the clinical history and what the consultant has noticed is mismatch, and the procedure is stopped over here. The review of the incident logs reveals it revealed that at least 7 smears involving wrong patient, wrong procedure or wrong set risk in the 6 months. So you can understand there is a link of incidents of the near miss which were being identified by the quality team, were identified by the team members actually who are working on this particular topic with respect to patient identification. None of these were escalated beyond the ward level reporting, though the people in the system were knowing it. Sometimes actually it was being even talked of, or but it has not escalated actually to the level of reporting, or might be they might be in a fear or a blame culture risk actually that they have not made them to come up with incident logging actually. Then on working on this project ahead and analyzing it, the staff interviews were taken. Nurses feel reporting near misses lead to extra paperwork and blame. Where when I was trying to talk to you about making it more clear to the staff or even the support staff also to make it more visible that when there such of the near miss happen, it also should be reported. Which they find that it's extra paperwork and sometimes the blame may come about their skills and their reputation. The junior doctor assume that some else will catch the error. They will say that it is a more an ignorance on their part, or sometimes it is being identified that they also lapse or lack into their work. So no formal HFMEA has been conducted for patient transfer and handover process till now. So the interviews are being seen very evident to say that there is a focus of leadership primarily on infection rate and financial indicators with minimal attention to patient identification. So somewhere or the other, there is a fault of the leadership, there is a fault of the patient transfer policy, handover policy, junior doctors and nurses to be seen in all the staff interviews. When your attention of your administration is more towards the financial indicators and other making your hospital more shiny rather than not working on the minor to major issues actually from patient identification towards the quality control. What are the key issues which are identified over here? It is that repeated near miss not triggering proactive risk assessment, which is a very clear to be given as a statement. Weak safety culture and underreporting, where it is more that you are making the safety concerns or safety issue to be questioned and you are also not reporting. On the larger part, it can be seen as a key issue of poor governance oversight of high risk processes, which is very important that you are ignoring the patient handling or patient identification. And absence of standardized handover and identification checks were not being seen. So all this can come up to be a strong recommendations after coming ahead with each and every issue to be dealt in detail. Now, the structure solution approach. We have identified this and now we are going on the RCA of this. The purpose to understand why near misses are occurring, we have to go with the root cause analysis of this. The causes will be analyzed as immediate causes are failure to verify patient identifiers, reliance on verbal communication, which is the very commonest way of immediate cause to be seen as. There are contributing factors also which instigates or initiate this, which is like workload pressure, poor infrastructure, inadequate handover protocols, inconsistent wristband use, and sometimes being seen all these contributing factors which are fueling to the immediate cause to happen. And on root cause, you may come across that blame culture, that is a blame oriented culture which discourages this reporting. Though many times it has been identified by those people, but they are not reporting it. Lack of leadership and attention towards the handover safety is not being seen as a major in the root cause. And no system level risk analysis of transfer process was there. So you may come across a very important finding from the RCA towards the immediate response for the root cause analysis. In the step 2, we may come across a cultural analysis. What is the culture? There is a culture of fear of blame, a disciplinary action, or normalization of the deviance where nothing will happen as happened in the last time and I should continue with this. Discuss accountability with across the department and no one or the entire or no hospital responsibility is being seen as. So it creates a question mark on the cultural issues that identifies to make that there is a poor culture of safety. Cultural interventions can be seen as introduction of a just culture policy to make it more fair, more clear and more in accountability to from the top to the down. Leadership communication emphasizing more on learning over the blame rather not identifying and excluding people for that. Anonymous near miss reporting mechanism is also very important way of cultural interventions to be identified for this one particular problem. Step 3 deals with governance and leadership review, where the governance gaps, no oversight of patient transfer risk. The governance part need to see that a risk register not updated with near miss trends needs to be followed up and actions to be taken with respect to such issues happening. No multidisciplinary risk committee review was being seen and which is also being taken as a governance gap. With respect to leadership, the actions count as establishment of patient safety committee, which is a need for every hospital or healthcare institution to take ahead this as a policy, which needs to establish a patient safety committee with respect to member working under the leadership of the top management. Mandatory quarterly review of near miss data. The patient safety committee with respect to the authority actually need to take a mandatory quarterly review of near miss data. The leadership should walk around focusing on handover safety. They can see into the ward, they can come across to the case site actually or can work with team actually to identify the issues with respect to patient safety. Now, the HFMEA proactive risk assessment. When you have taken the HFMEA proactive risk assessment, the topic was identification and clinical handover during the intra-hospital transfer. The failure was being seen that a patient transferred without identification barrier, wristband was missing or was illegible, incomplete handover communication and assumption based verification. So this is one which you can see as a key failure. What is the risk being given over here? The severity is like catastrophic, a wrong procedure which gives 4, probability of occasional which gives 3. And what is the hazard score? That is 12. The action is required a lot actually into this. Action plan development, prevent control, mandatory twice verification at every transfer, standardized handover checklist, barcode based patient identification, training on handover safety for all the staff, which is very important to make them understand what culture they really need to work on rather than reducing actually what existing they are doing it. Making it more on the accountability part to ward in charge who are taking the responsibility for reducing the compliance. Radiology head responsible for verification and the timeline need to be given for 2 months actually to work on this to improve the compliance for this. Step 6 will follow with the follow-up and review, where the monitoring and outcomes are very important. Monitoring will be done on monthly audit of handover compliance, tracking the near miss trends actually which were there and now in current, and recalculation of the hazard scores and working on reducing the scores and making more better compliance. The outcomes will be like improved reporting culture, reduced near miss events, and strengthen leadership visibility in patient safety, which will be reflected into the entire organization. So this integrated case study of breakdown in patient identification and handover, a system culture and risk management perspective, we have seen the entire scenario. We have gone across with the immediate response versus to cultural analysis, governance leadership review, and HFEA risk assessment, action development plan, and follow-up of this, which is more being visible that this case gives a more problem statement context and is working on the RCA rather not giving a blame culture or even on reliance on verbal communication or on leadership which is focused on financial and no prior HFMEA, but were reducing the blame culture, not relying on the verbal communication, and a leadership which is more focused on patient safety culture. The key learning of these two case studies gives us more insights about a high risk clinical process often contain single point failures. The failures might be like a surgical swab counting or a patient identification and handover, where you can find even the rare to rare errors can result in catastrophic patient harm. You cannot ignore it actually, or you cannot miss it. So where we can say risk is not only a risk, but it can be seen as a high risk with respect to clinical processes, and often it has a chances of leading a failure. HFMEA is enabling us to a proactive identification and prioritization of the risk by systematically analyzing the failure modes and giving their causes and hazard score before the adverse event has occurred, which is very important to take before the action plan and even work on the RCA that is helping us to explain why incidents are happening. While HFMEA focuses on the preventing future reoccurrence through the system redesigning, is very important to make it more clear to our understanding that how you need to work on the safety culture, how you need to take the benefit of the governance and the commitment of the leadership in reducing it. And lastly, in this discussion of these two case studies, the benefit is more towards like sustaining the risk in reduction, which requires a structured action plan. It is not that you have understood through an assessment, you have identified the reasons, but you are not able to work on the action plan. There is in addition to the work on accountability and continuous review to contain it actually, or to maintain actually what is being supported by the help of the audits, the leadership oversights, and a just culture approach towards developing a better future to the patients and reducing maximum patient safety issue. With this, we come an end to this chapter where we have given more focus on these two case studies with a practical application which can be even seen as a benefit to your organization when you are trying to take and understand these case studies. So try to make a project actually which will help you to understand the risk, to work on this FEMA model, and you can get a better outcome of this. So thank you for your patience listening, and try to take a benefit of these references and go in detail to understand when you are trying to make a risk management plan for this. So thank you very much.